lab, and it comes to us during lab week. So we're really excited to have these fantastic speakers joining us today. But before we get started, I just wanted to give some ground rules for today's session. I'm going to ask our presenters to mute themselves if they are not presenting, just so that we don't have any background interference during the presentation. For all those who are joining us across the globe, please feel free to type your name into the chat along with your affiliation. We'd like to see who's joining us today. And at any time during the presentation, if you have a question, please use the Q&A chat function to type in your question. They will be addressed at the end of the session. Our session will also be recorded and posted on the ICAP website so that you can access it post today's webinar and share with interested colleagues. So without further ado, I'll pass it on to Dr. Jessica Justman, who will be moderating today's session.
Terrific. Thank you very much, Fatima, and good morning and good afternoon to all of you who are joining us. As Fatima said, we are really pleased to be having our grand rounds focused on the role of laboratories, particularly public health laboratories, in the current laboratory week that is going on right now. Laboratory Week is an opportunity to celebrate the very valuable role that laboratories, including public health laboratories and medical laboratory professionals, play in the diagnosis and the monitoring of diseases that help us do a better job with healthcare and with responding to public health needs, such as COVID. So really very timely. Our first speaker is Dr. John the Kangasang, and I'm very, very pleased that he's able to join us. John currently serves as director of the Africa Centers for Disease Control and Prevention, which is a specialized technical institution of the Africa Union, and he's based in Addis Ababa in Ethiopia. And I'll keep his bio very brief because we want to, get all the time that we can to hear John's remarks. I'll just tell you that prior to his current position, he served as chief of the International Laboratory Branch at the Division of Global HIV and TB at the U.S. Centers for Disease Control. And he also served as acting deputy principal director at the Center for Global Health, also at CDC. So John, please, let's go ahead and hear your remarks. And terrific, thank you.
Thank you, Jessica. I just wanted to request that I can share my screen and then my video as well. If you can let me, okay, good. So
yes, we see your slides, although we don't have the presenter's view. If you want presenter's view, there you go, perfect. Okay,
good. And so what I would do is divide my, I know this is really focused on lab and I appreciate this. And this is, I'm excited to be part of this and thank you for inviting me. And I'll focus on the SARS-CoV-2 sequencing in Africa, how we are tracking variants. But I thought it would be good to do that in, at least put that in context very quickly and spend a few slides with you, telling you all where the pandemic is in Africa. As we speak today, 4.4 million cases have been reported across 55 member states, of which 3.9 million have recovered, with 117,000 deaths, with a case fatality ratio of 2.7. If you look on the right-hand side of the curve, it shows you mainly the number of new cases reported every day. The red line in particular shows you the 7 days moving average. I mean, the message on this slide is that we've gone through the first the wave, second wave, and potentially going through will be creeping up towards the third wave. And I'll show you some slides. The different colors you see underneath the moving average are the different regions of Africa, the 5 regions of Africa, that is the Southern, Northern, West, Eastern, and Central Africa. If you now look at the number of COVID cases that we are reporting per day by AU member states, this slide clearly shows you that, there is the green colors, which is predominantly here. We're reporting about less than 5 cases per 1 million per day. And then, of course, you have the 4 countries at the top end there reporting more than 100 cases per 1 million per day. The point I wanted to really emphasize here is that before I go to the sequencing part is the case fatality ratio on the continent has actually reversed. We, early on during the first wave of the virus and the pandemic, the case fatality ratio was 2.2%, and now we are at 2.7%. And you can see that there's a whole host of countries that are 18 countries plus the 4 at the bottom that are reporting case fatality ratios that are way above the international or the global case fatality ratios. Now, the trends in the different regions of the continent, and just for the record, we have 5 geographic regions of the continent. The Southern African region is recording, had over the last 4 weeks, a decrease of about 43%, West Africa about 46%. However, in North Africa, you see that, and Central Africa, we continue to see either beginning to see an increase in the number of new cases or already a significant increase in number of cases. Central Africa, actually, as you see on the right-hand side, is going through a severe second wave. Then East Africa is actually going through a third wave. And I would like to rush to Kenya just to show you the 3 different waves in Kenya that are driving the pandemic. First of all, the wave 1, wave 2, and 3. And each time you get in the subsequent wave, the peak is higher than the previous one. I think that is the hallmark of what we are seeing across several countries there. And this is Ethiopia. We are going through a second wave in Ethiopia. Around November, December, up to February, we thought that we're on top of things, but clearly the last 4 weeks have seen a very sharp increase in the number of new cases. And the peak, as you can see, is now higher than where we were in August, September last year when we peaked. So, and this is Tunisia, just to conclude that chapter. So we published these findings just about 3 weeks ago in the Lancet for those who are interested in reading more about the first part of this, which is we characterize it as the first and second wave. And then we also noted that the case fatality ratio, which I mentioned earlier, was more significant in the second wave than in the first wave. So this is just a slide that tells you some of the significant progress that happened over the last couple of years, the last couple of months with respect to the initiatives that Africa CDC launched at the level of head of states to fight the pandemic. So one of those was what we call the PAC, that is the need to accelerate testing. And this is a segue now into the lab piece of this conversation. We recognized early on last year in April, May timeline that as a whole continent, we had conducted only about 350,000 cases. This is a continent of 1.2 billion people. So we launched the partnership to accelerate COVID testing with an initial target of conducting about 10 million tests, which was exceeded. As we speak today, the continent has conducted about 42.3 million tests with 9.6 tests per reported case and a positivity rate of 10.5%. We have also supported member states with about 4 million antigen tests roll out, and the graph here shows you how those numbers have actually changed over the period of since November last year and now. I think we continue to make sure that countries are testing sufficiently in order to track where the pandemic is going. And this slide just shows you some of the test positivity ratio across different member states. Very importantly to note that at least 18 countries are reporting test positivity rate between 2 and 7%, but 15 countries, the last bar there in dark red, are reporting test positivity rate of more than 10%. Now, let's go to the genomic part of it. Last year, in 2018, we started doing an assessment in preparation of setting up the Pathogen Genomic Institute. And by 2019, that is before the COVID-19, 22 institutions in 11 countries have been assessed, and data was all assembled and analyzed. And we published the details of these findings in Lancet Infectious Diseases just early this year. Essentially, the findings that we did, this is all before COVID-19, led us to the establishment of the Pathogen Genomic Institute at the Africa CDC, with a vision of integrating pathogen genomics and bioinformatics into public health functions for disease outbreak investigations and improving disease control and prevention in Africa. There were 5 cross-cutting areas of the Pathogen Genomic Institute. One was an enabling mechanism and policy and guidelines. Then the second was a pathogen genomics and bioinformatic network across the continent. Then the third area was capacity building. Data system was critical, and genomic epidemiology. We recognized that it was important to have an impact that will lead to a rapid and timely response to infectious diseases threat across the continent. Then COVID-19 hit. And because we already had the network in place, it was easy for us to support countries. And if you look at the map carefully, those in dark blue colors are those countries that Africa CDC have supported with sequencing capabilities, training, or webinars across. And those in light blue, mainly Botswana and Malawi, are those that we will be supporting subsequently. Our goal is to make sure that we bring every country into this Pathogen Genomic Institute network that we launch. And these are some partners that are working with us: the Bill and Melinda Gates Foundation, Illumina, the US CDC, Microsoft, Nanopore have all worked with us to establish this important Pathogen Genomic Institute and initiative, which has been going on now for the last couple of months. So a little bit about the key components of the initiative. There are 5 of them. One is to strengthen Africa CDC's Institute of Pathogen Genomics in leadership, enabling mechanisms, and pathogen genomics community of practice. Second is to build our Africa Pathogen Genomics and Bioinformatic networks. Then thirdly is data architecture. Next Generation Sequencing Academy has also been established and launched, actually, an implementation of high impact genomic use cases using existing challenges like TB, malaria, and HIV as use case scenarios. If you look at the way we are set up, it is actually in 3 different layers. At the top of the whole network are what we call specialized genomic bioinformatics centers. And you have one in Nigeria headed by Christian Happy. And then in South Africa, 2 of those specialized centers exist. Just below that are the regional COVID-19 sequencing labs at the Institut Pasteur in Morocco, Senegal, at the Nguchi Institute in Ghana, Nigeria CDC, Professor Moyembe's lab in DRC, SIMS, UVRV in Uganda, KEMRI, and National Institute of Communicable Diseases. So we all work in network. Below that are national labs that are working with us, and the whole goal is to coordinate efforts so that we can at least maximize and create efficiencies. This is the system that we use in collecting specimens, analyzing them, that is, to collect specimens from those countries that do not have the sequencing capacity, send them to other regional labs or to specialized lab. They are sequenced, the data is communicated back to the member states and used for action. And I'll show you subsequently in the next few slides some of the results in this. So this slide begins to show you where we are. As of 19th of April 2021, we've through this network generated 6,281 referral specimens. That is just moving specimens across the continent from 25 and 25 countries are pending their samples to be shipped. Then if you look at how much sequences we have generated, about 11,431 sequences have been obtained from 37 countries. The size of each pie here on the African map represents where most of those sequences are coming from. So from Southern Africa up north, you have South Africa, of course, Kenya, then in Central West Africa, Nigeria, Cote d'Ivoire, Ghana, and Senegal are all generating significant number of sequencing. Our goal is to be able to sequence 50,000 genomes by the end of this year, so that we continue to get a comprehensive view of what is going on the continent. This slide shows you what we did last year in 2020 and what we have generated so far, as I indicated, in 2021. And the beauty is that we are not yet there. We hope to get to 50,000, but we are making steady progress towards achieving that goal. And the slide here shows you some of the results that we have obtained. The green colors are the so-called South African variants. The red colors are the so-called the UK variants, and those in orange are where countries where both variants have been identified. As you can see, the South Africa variant is mostly clustered around the Southern Africa region in those countries next to South Africa, even though Cameroon has been has reported the South African variant. The UK variant are predominantly in the northern part of the continent and the west and in West Africa. So we continue to track that very carefully. If you look at this slide carefully and you look at the shift in the variants over time in terms of frequency, you see that clearly that the South African variant is beginning to become predominant progressively on the continent, which is, if you compare that or contrast that with the UK variant, you can see that it's almost very stable. So we are very concerned that this South African variant may actually become the predominant variant across the continent and will pose significant threats to the efforts we are currently doing to roll out the AstraZeneca vaccines. So this slide also shows you the variants of interest. 8 countries have reported the B1525 variant. 7 countries are reporting the 8231 variant, and 3 countries are reporting both, and you can see them on this map. So my thinking is clear. We have not seen the end of this variant, and that is why it is so important that we continue to strengthen capacity, work as a network, so that we understand how these variants are spreading across the continent. Let me just summarize and conclude with some challenges we are having. Limited sequencing and bioinformatic capacity at national level. The regional labs and the specialized labs are doing very well, but at national level, it's still a struggle. That is an area that we need to strengthen. We need to standardize sampling frameworks, tailor that to and with some nice epidemiology, lengthy processes of approval, the MTA, that is material transfer agreements and import permits, logistics and custom challenges, and standardization of metadata, protocol, data analysis, and pipelines and reporting are areas that we continue to improve on. Let me just conclude by acknowledging multiple partners that are working with us. I've been a huge number of partners, and they are all growing every day, and we look forward to including ICAP as part of our network so that they can bring their expertise, and we understand how the variants are spreading across the continent. So let me just conclude there by thanking you again for the opportunity to be part of this very important discussion. Over.
Wonderful. John, thank you so much. And I know that you're on a very tight schedule, and so you won't be able to stay around for questions afterwards, but perhaps we may forward some of them to you by email and get our answers back to others later. I think if I can just ask you for 1 minute to talk a little bit about that one of the last challenges of getting a standardized sampling framework together. What is the status of that now for the sequences that have been done? Do you have much information on how those samples were selected? Just how representative a picture are they?
Yes, I think that is the key question. That we are very cautious that and that is a common advice we provide in the network, that we should be very careful how we interpret the data. That is not because somebody travels, say, to Cameroon, and you pick that individual at the airport because most of these countries are doing testing at the airport that immediately color the whole country green or whatever. You have to look at a standardized protocol that is used all the time and then to track what is going on. And that is why you see on the graph that I tried to show you how the B135 variant and the B117 variant are evolving. I mean, it's because we have that standardized protocol now that some countries are using so that we have at least a moving picture of where we are going with that. But it's not yet universally used, and we hope that that will be in the future. When very near future, we'll continue to make sure that that protocol is used, which we've developed, is used across all member states.
Great. Do you have time for one more?
Yes, I do, please.
Okay. So these are some questions coming up about issues with supplies for test kits. So what are some of the moves to increase access to existing test kits, either through decentralization or through integration into regular health services? That's one question. And the other one I'll ask you is, what do you see coming down the road in terms of self-testing for COVID on the African continent? So
I must say that the testing bottlenecks keep improving every day. If I see where we were last year and you see where we are today, I think I must say that a lot has happened with both the traditional PCR test, molecular test, and the antigen test. I mean, you can see, I didn't show the graph, but you can see a rapid uptake of the antigen tests across several member states, and as well as many labs. I mean, when we started, okay, it was, and we started the trainings in Senegal and South Africa, Jessica, there was, each member state went home with 100 tests, okay, after the training. That was last February and March. I think we are just barely 1 year. So if I look at the situation 1 year ago and where we are now, where there's abundance of tests, there is not yet, of course, because of the molecular nature of the test, it's not yet everywhere, but at least countries like Nigeria that we all know very well, so many labs. Chikwe has done an amazing job to roll out testing across so many labs now across the continent. Now, is that enough? No. I mean, we should be able to, hopefully that the new generation tests will allow that we actually embed that into our TB and HIV testing program so that they become almost routine testing. That is where we are going to really begin to make a big difference in our testing efforts. With respect to self-testing, I think it will be a question of what kind of tests. I mean, that will enable you to, because the serology tests are still very, we are not yet there. I mean, then you're left with the antigen tests. I mean, antigen tests, again, we know that, I mean, you have to work with them carefully. So my preference would be just that we make the test so available that people can test themselves all the time so that they can do the right thing. My fear is that if we do not do that, we are slowly moving towards endemicity of this virus in Africa because of the slow nature of which vaccines are being rolled out on the continent. Our target was that by the end of the year, we would have vaccinated at least 30% of the population. With all what is going on in the vaccine world, I don't think we'll do that. And if we do not do that, I can see that we begin to change our thinking, how to approach this virus from a pandemic to an endemic disease.
Right. Okay, well, we'll let you go. So thank you again for joining us, and all the best. So
Thank you so much for inviting me.
Great, wonderful, thank you again. So we're going to turn now to our next speaker, Dr. Debra Wadford, who is a licensed microbiologist, and she is with the California Department of Public Health and leads the viral and rickettsial disease lab branch, and has been doing that for many years. And most recently with the COVID-19 pandemic, Dr. Wadford has led a state public health lab in its response and has served as the lab lead for the coronavirus science branch at the California Department of Health, and has led California's SARS-CoV-2 whole genome sequencing initiative. and we're going to get to hear more about that. Dr. Wadford.
Thank you so much. And I'm going to share my screen now. And thank you to the organizers for inviting me, and I'm happy to be here during for Lab Week to commemorate really all the efforts, the hard work and efforts of all the laboratorians and actually the medical health professionals through this year of, it's been a year, hasn't it? Let me see if I can figure out how to share this screen. I did it earlier. Okay. Thank you. Somebody else? Yeah, thanks. Appreciate that. Sorry, I could not figure it out.
Nope,
okay.
it's perfect. You're good.
I don't think I don't think I have control though. So thank you. I'll just tell you when to slide advance. So I'm going to give you a public health laboratories perspective of the COVID-19 response. I'll touch on where we are today with COVID, talk about the testing and trends that we saw from the laboratory testing, and touch on whole genome sequencing really throughout my talk. And you will see that whole genome sequencing has been with us since the beginning of this pandemic. And then all of a sudden in December of 2020, we heard about this variants. What the heck? And again, whole genome sequencing came into play. And then I'll finish with a summary. Next slide, please. Thank you. So just as an overview of where we are today with COVID globally, probably more than 140 million people have laboratory confirmed cases. It's vastly underestimated, no doubt about that. Almost 3 million people have died. And if we look specifically at regions throughout the globe, we can see there has been no region that has been spared. And the numbers there indicate the different waves that we have seen since January of last year. Next slide, please. And then if we focus in the United States, looking at, again, the waves, we've had 3 waves, each progressively worse than the previous. And this past one has been an incredible surge that has challenged us all in many ways. When we had more than 300,000 cases in one day, the impact on the medical professionals, the citizenry, and of course the laboratories was incredible. Next slide, please. So the testing in the US, so early on in the pandemic in January and February, once the sequence of the virus was published, and that was on January 10th of 2020 by China scientists in China. And at that time, the whole globe used that information to develop diagnostic tests to identify and detect that virus. In the United States, that test was also developed based on the sequence data, but the test was only available at the US Centers for Disease Control, and it was limited. They only accepted specimens from patients who had COVID symptoms and also recent travel to China. Severely limited the number of people getting tested. And at that time, we were not aware that this virus could spread asymptomatically. By the time March rolled around, finally, we were able to ramp up testing. Testing was available at public health laboratories initially, and then at clinical laboratories, and we were able to increase the testing. Of course, once the testing increased, we were slammed, punished by severe supply shortages, which impacted not only the testing, but also our frontline healthcare workers in terms of the shortage of personal protective equipment. And then collecting of specimens was greatly hampered by shortages of swabs, testing media, and then test reagents. And now we're enduring plastic shortages. Next slide, please. So I superimposed several hallmark time points on the epi curve that I showed you earlier. to show you essentially where we are and what we've endured over this past 14 months or so. And just really want to hallmark that almost at every step prior to a wave, during a surge, we have had to endure some setback. And finally, at the peak of the surge in December, we got the great news that the Pfizer and Moderna vaccines were approved. And that was such really a breakthrough. And then right in the middle of that, we heard about this UK variant, the B.1.1.7, that the United Kingdom and their incredible efforts with genome sequencing had uncovered the B.1.1.7 variant that had started taking over and predominating the virus in their country. And then that was also starting to be seen in other countries. Next slide, please. So let's talk about whole genome sequencing going back to the beginning. Next slide, please. So in January and February, here in the United States, the first case was reported from Washington State on January 20th. And then the other hallmark I wanted to call out here was the first community-acquired case that was reported on February 26th in California. Next slide, please. So if we look at the phylogenetic tree of these two cases, and I've called them out here on this slide, and this slide is from Dr. Trevor Bedford, who's a leader in genomic epidemiology at University of Washington. And his lab characterized the first case from Washington, and he also generated this phylogenetic tree. And I want to call out a couple things here. The red dots, each dot represents a virus that's been sequenced from a patient, and then the other colors represent different regions throughout the globe. You can see that there's one tree that is predominant red up in the upper right corner there, and then but you have some other branches that are red, and those are all from Washington State, and then the other colors that are not blue would be South America and also North America. And you can see California, that first community acquired case, was in the midst of the Washington tree and clade. And another thing I wanted to call out in this slide, as I circled the dates there, and you'll notice that between January 19th, the first case, and February 26th, that first community acquired case, that's a span of 5 weeks. During that 5 weeks is when we were so limited in our ability to diagnose this virus in the community. And again, we don't know what was happening really in that time span because we didn't have widespread testing available. Next slide, please. And in Northern California, we saw the same, very similar pattern where we had multiple cases, but again, under detected. But the characterization of those cases is that they weren't just from one introduction and then a local transmission. It actually was indicated, just as it was in Washington State, that we had multiple introductions and then local transmission subsequent to those introductions. Next slide, please. And so from the testing that we've done since the beginning there at the end of February, and then to now, there are several things that have been revealed, again, from laboratory diagnostic testing and whole genome sequencing. The first thing, we recognize that there were multiple independent introductions and then subsequent local transmission of the virus in each community. Asymptomatic cases were actually possible and spread. From there, we also were able to detect and characterize reinfections, detect them diagnostically, but then characterize them using genomic techniques. Another hallmark here from testing revealed that vulnerable populations were really at risk of severe outcomes, and particularly in congregate settings. And we saw this over and over from nursing homes as well as prisons. And when we looked at those outbreaks, we were able to categorize them in terms of the what clades they belong to. And we saw examples of both a single introduction into one facility that just ran rampant subsequent to that introduction, but we also saw situations in facilities and institutions where there were multiple introductions, presumably from staff who came to work, and different viruses spread through the institutions as well. Testing also revealed that underserved communities were impacted disproportionately, underscoring health disparities that we know exist in the United States and of course elsewhere. And then our diagnostic testing finally revealed, once we got into the age of variants, it was clues to possible variants due to gene target dropouts. Next slide, please. Next slide, please. Thank you so much. So let's go now back to whole genome sequencing now to talk about the identifying variants. Next slide, please. Thank you. So why all this concern about variants? Well, there are several reasons, and they've been demonstrated, particularly with the B117. So they may transmit more easily due to the acquisition of certain mutations, which would lead to increased infectivity. They may be more pathogenic or virulent. They also may evade the immune response, which could impact vaccine efficacy and also make the host more susceptible to reinfection. And then lastly, the diagnostic tests that we have are specifically designed targeted to known genome sequence, right? And so if the mutation is in a targeted region, which we have seen, then we might not be able to detect those with the tests we have. Next slide, please. Okay, so I don't know if you can see the top of this slide, sorry about that, I packed it in there. But if you remember one thing from this talk, I hope it is that it's viruses mutate. And the other important thing here is that not every mutation is biologically significant, and even the presence of a known biologically significant mutation in and of itself is not cause for too much concern. Okay, we're focusing, when we're talking about variants, the focus really primarily is on the spike mutations, specifically within the receptor binding domain, because it is that domain that sort of dictates whether that virus is going to be able to infect the host. The 501Y, which we see in the B117 variant, as well as in the B1351 and the P1 variant, it has been associated and looks for sure to increase transmissibility. And then the other notable mutations, 3 of them are also in the receptor binding domain and have been associated with immune evasion. But please note that the only way you can definitively identify a variant is by whole genome sequencing. Next slide, please. So I've summarized just some of the characteristics of the variants of concern here, starting with the B117 at the top. And I've included the transmissibility characteristics, as well as the ability to evade the immune response. And with respect to there are 5 known variants of concern right now. I would focus on the B117 and the B1351 and the P1. And those 3 do seem to show increased transmissibility. And actually the last category of the so-called West Coast or California variants also show a moderate increased transmissibility. And they all show immune evasion, except for the B117. Next slide, please. Thank you so much. So in terms of the B117, based on its increased transmissibility and what happened in the United Kingdom, Denmark, and other countries where it has seemingly just taken over, likely due to that increased transmissibility, the Centers for Disease Control did some modeling studies that suggested, and they actually predicted here in this article, the MMWR, that the B117 would become the predominant variant in March of 2021. Next slide, please. So with the sequencing efforts that have, again, been going on since the beginning, but of course, I think everyone is aware here, and if you're not, I'll let you know that in 2020, although we had sequencing capacity, we certainly were not anywhere near reaching what the COG UK had done, what Denmark had done. And it became really obvious to us in December when the variants began to emerge that here in the United States, we needed to increase our genomic surveillance. And I think the Centers for Disease Control has certainly done an excellent job in trying to get that capacity up. And what they have done really to benefit the public health laboratories with this is that they have, again, doled out grant money that has let state laboratories, but also local laboratories, build their infrastructure to do genomic surveillance and sequencing. And also, that is to answer and respond to COVID-19, but also building that infrastructure, investing in the public health system is going to get us set and ready for whatever comes next. And we know, ladies and gentlemen, that there will be something next. So the genomic capabilities in the United States has increased a lot. And so we have, I think the Centers for Disease Control deserves a commendation for doing that, as well as, well, we're getting where we need to be. Now, if you look at this particular graph, this histogram, it shows sequencing and the variants that have been detected with the genomic surveillance that we've done since January of this year, 2021. And I want you to notice the sort of growing peach part of that the histogram as we move down the line. And you will see that in January, it's a very small peach bar. That's the B117. And then as we move every 2 weeks, that's the bar. As we get to the end of March, lo and behold, the B117 is the predominant sequenced virus here in the United States. So it looks like that has come to fruition, that model, and that virus is definitely doing well compared to other variants. Next slide, please. So in closing, I just want to underscore that the lack of the ability to do diagnostic testing for this novel virus, that's a big reason we weren't able to really do a lot of testing early, probably led to a lot of the cryptic spread and the situation we're in today here in the United States. Testing did reveal that both symptomatic and asymptomatic cases were distributed throughout the country. It really highlighted our vulnerabilities with respect to the supply chain. And that's not just exclusive to the United States. It really was a global crisis. Health inequities and ethnic disparities were highlighted and are something that we need to do a lot to address. And then with whole genome sequencing and genomic surveillance, we were able to characterize outbreaks, also to monitor the emergence and the continued spread of different variants and identify variants of concern as well as variants of interest. And then finally, all of the genomic surveillance and the diagnostic testing really provides the data that's critical to inform public health action to improve the situation locally, statewide, and of course, nationally and globally. And I will end there with the next slide, just happy Lab Week. And my hat is off to all the laboratorians out there for all you do. Over.
Well, that was really, really wonderful, Deborah. So clear, so many important points. So thank you very much. I'd like to ask Dr. Ing Pottinger, ICAP's senior lab advisor, to start by just giving us an initial comment on the talks that we've heard and perhaps posing a question for you, Deborah. Ing.
Great, thank you, Jessica, and thank you, Debbie, for agreeing to present today. I know it's very early in California, and most people don't know, actually, Debbie and I were in grad school together, so we've journeyed a long way through HIV and COVID now together. So Debbie, I laugh through, listening to John and you and talk about whole genome sequencing. I guess, a question that you read about and hear about is really, what kind of sampling, what's the percentage of the positives do we need to be sequencing to really have a good readout on, what's happening with the virus and how it's evolving in a population? Various numbers have been thrown around in terms of what that number should be, but I'm curious as to what you think, how much we should be sequencing.
Yeah, it's an excellent question, Ing, and we have sort of mulled that over and over and over. And if we use the COG UK as well as Denmark, and those are probably the top countries right now who have excelled in terms of genomic surveillance, those two countries have their goal is about between 10 and 11%. And I do believe there are other countries that that are going for 100% of the positive cases. That certainly is not something that's reachable at all here in the United States. And in California, we have had, we performed nearly 60 million tests, and we have over 3 million cases. And trust me, when we were in the early days of the first surge, we were thinking, how many do we need to sample to get an understanding of what strains are circulating? And early on in May of 2020, the California Testing Task Force established COVID-Net. It was the California Whole Genome Sequencing Initiative for SARS-CoV-2. And we dubbed it COVID-Net as a network of laboratories throughout California, not just the public health laboratories, but also academic institutions. The Chan Zuckerberg BioHub really spearheaded this under the leadership of Joe DeRisi. And so they were providing tons of sequencing, up to 4,000 a month, which doesn't seem much, but it was a lot at the time, early in the pandemic. And we convened a panel of world-renowned genomic experts from different institutions in California. We were in lockdown. They wanted to help, and we could certainly leverage their expertise and knowledge. And so we had mathematical modelers such as Mark Suchard, Christian Anderson, leader in genomic surveillance, and several other academic leaders. And we asked them, we posited that exact question to them: what would be the appropriate percent of the positives to sequence so that we're not overdoing it and we're not underdoing it? And really, they wanted us to keep it simple. We knew we couldn't reach 10%, but the number that was decided upon by that panel, and it was an informed, educated suggestion, was between 2 and 5%. And given the status of our sequencing capabilities at that time in California, before any influx of funds from the government, federal government, we set out to do just that. And at this point, we failed miserably. I think in December we were at about 0.3 to 0.4% of all positives had been sequenced, which is pretty much in line with a lot of the rest of the country. But again, California had many, many more cases in many more states. However, now we've sequenced in March about 6%, which is great. Of course, we haven't had that many cases, which is great, but we don't know what's going to happen next. So Ing, to answer your question in a really long way, between 2 to 5% minimum we would like to sequence. And that really is based on the model of influenza and right sizing to get an understanding, again, of the situational awareness and to detect variants that might be of concern at lower levels that might be emerging. Over.
Great, thanks, Debbie. And I want your take on the home testing, and there's a question in the Q&A regarding home testing. This past couple of weeks was a bit momentous. For those of you who may not know, the FDA did approve a home test that doesn't require a doctor prescription, and you can buy it online, and hopefully they'll be in your pharmacies. It's called Lucira, and it is a at-home PCR-based test, and it's actually quite phenomenal if you think about it. I think, Debbie, there might be one other one that is similar, but the at-home tests up to this point have been, we send you a swab, you send your sample back, and we'll process it in a lab. So this is a major breakthrough, I think. It comes with all the accoutrements, including a heating block and a readout, so there's no interpretation issue. What do you think, what's the role of home testing going forward? And do you think, at a $55 price point, is it limiting or is it advantageous?
Yeah, thanks, Ing. I mean, it's so important that we get people tested. That's one of the things that we sort of blew it in the early part of the pandemic. Even though we've done a lot of testing, we need to do more testing. And I think with the release of the vaccines, a lot of the focus on testing has sort of diminished. And we have seen in the public health labs, for sure, a decrease in testing demand. And that's exactly the opposite of where we want to go. So I think these home tests are great because they're going to get more people tested who likely would not have been tested. There's the other side of the coin there, because those people that are going to be testing at home, and if they're positive based on those results, will hopefully do the right thing and stay put. But those samples are likely never going to see the laboratory and never reach the sequencing bench, right? So that's one aspect where there is some concern, particularly from the public health side. But in terms of just responding and stopping this pandemic, the more tests available that are good tests, the better. We need people to be tested.
Thanks. And, before I hand it back over to Jessica, I just want to say thank you for all your hard work. I know the public health labs in this country especially are, we don't maybe not appreciate you enough all the time. So I'm appreciating you and your staff. I know what the early days of COVID testing were like, especially during that 5 week when we had no COVID tests, and you and I shared a lot of frantic phone calls during that time on how to get more kits. So given that this is Lab Appreciation Week, I want to appreciate you, your staff, the other public health labs, and all of our staff globally on your hard work.
Yeah, thanks. Thank you. And back at you, my friend.
Right. Okay. So I want to just encourage our audience to raise your hands if you would like to have us enable your microphone so that you can ask a question. Of course, you can also put a question in the chat box. And in the meantime, while you're thinking about questions that you might like to ask, Debra, I will ask you any concerns about any of the specific variants interfering with the performance characteristics of the diagnostic tests that we have, whether antigen-based or PCR-based. I think that's something that could keep one up at night. And I'm wondering how much you're worried about that, and which one or ones of the variants you think might wind up eluding some of our diagnostic tests.
Yeah, it's a fantastic question. And it really underscores the importance of laboratory tests and their design. And most of the tests out there with FDA emergency use authorization have built-in redundancy. So they target, and these are the PCR assays, they target parts of the genome of the virus that it's not just one target. So it's the tests that do the best and will safeguard us in the as you posit your question in terms of evading detection. So there are tests that, like the CDC test, for example, has 2 targets in the N gene. Another test has 3 targets in 3 different genes, and so on and so forth. And in particular, the B117 really gave us a clue in our diagnostic laboratories for particular assays, because with one test it showed a particular one of the targets dropped out. And why was that? Because that one specific target had a mutation in it such that the assay did not detect it, but the other 2 targets were there. And so when we're analyzing the results at the end of the day, we're seeing this pattern of, wow, look at these, there's 60% of these cases, they've got this S gene dropout, and that's indicative of the B117. But again, those would have to go and be confirmed by whole genome sequencing. So it's really important for tests to have a built-in redundancy. And with respect to the antigen test, because they're typically only targeted at the nucleocapsid gene, the FDA and the CDC, they're doing ongoing monitoring based on genomic surveillance, and then also in vitro tests to evaluate any changes that are known to see if they impact those tests. So I think we have it covered, but I'm never going to say that with COVID, because the next time I turn around, boom.
Right. So there's a question sort of picking up on, the home-based PCR test that Ing mentioned. And, I guess it's sort of an exercise of looking into our crystal balls and trying to predict when that kind of test might be more widely available. For example, in African settings, the price would really need to come down. And I think I'm going to ask you, sort of coupled with that, to think, and this is going outside of the laboratory, but to think about how much testing should we be doing? I think there's a lot of concern that testing frequency has come down. Would home-based testing basically fill that in? Should we be saying, well, everybody should do a test once a week? I'm just trying to sort of think down the road what the approach to testing should be and how the home testing would work. So that's a big, broad question, and you can tackle any part of it that you like.
Well, I listened to TWEVO, which Dr. Vincent Racchianello at Columbia, he's the moderator for that. And Daniel Griffin does the clinical updates every week. And I love what he says. Dr. Griffin says, never miss an opportunity to test, never miss an opportunity to vaccinate. And I just think if there's a chance and a need, it should be met. And with respect to Africa and other regions in the globe, we need to get vaccines to as many people as possible, as well as testing. So they go hand in hand, to be honest. And it's a big question. So I'm sort of going to just say we need to get as much testing and vaccinations out there as possible so we can beat this and move on.
Great. Makes sense. Okay, well, I think we are going to wrap up now on time. Thank you again, Debra, for just a marvelous talk. And I'm thanking John the Kangasang, even though he's no longer on the call anymore. But again, he also gave us just a terrific view of the perspective from the African continent on what's been going on with laboratories and laboratory capacity in the setting of the COVID pandemic. And again, this has really just been a terrific way to mark Lab Week. So thank you, Debra, and thank you to our audience for your engagement and your questions. Take care. Wait, our coming grand rounds. Fatima, you want
Yes. Thank you so much to the panelists and Jessica for moderating and Ing for your contributions as well. I just wanted to highlight that our upcoming grand rounds will be hosted on May 18th. And the topic will be emerging infectious diseases in the context of One Health, and that will be presented by colleagues from the University of California, UC Davis. So we hope that you'll join us for that session, and the recording of today's webinar will be posted on the ICAP website, along with links to our upcoming Grand Round schedule. So again, thank you so much. Stay safe, and we look forward to having you join us next month.